Dr. N Islam is the Chief Division of Vascular Surgery, Indiana Regional Medical Center, Pennsylvania. He is practicing in the field of vascular, endovascular, and minimally invasive venous and endovascular surgery. He is a diplomate of American College of Surgery and American College of Surgeons, and a member of the International Society of Endovascular Surgery. He is originally from the Dix Hill, New York, and he received his medical degree from University of Chittagong in Bangladesh. Of course, it is a matter of pride for us. And now, I would like to request Dr. Mohammed N Islam to deliver his speech on the topic of Endovascular Repair of Aneurysm, EVAR, and the helping hand of the radiologist. Ladies and gentlemen, Dr. Mohammed N Islam.
Mr. Chairman and honorable delegates, my name is Mohammed N Islam, and I'll talk very briefly about the endovascular repair of the aortic aneurysm and how a combined teamwork of radiology and the vascular surgeons can make a difference. So before I start, once again, Assalamu alaikum, Namaste, and good afternoon. I bring you greetings from Indiana Regional Medical Center in Pennsylvania, where I'm the Chief of Vascular Surgery and also the Director of the Endovascular Cath Lab. Those of you in the audience possibly remember this TV show, I Love Lucy. Miss Lucille Ball was an American icon who entertained people throughout the world for many generations. Unfortunately, in 1989, on a sad morning, she was brought to the emergency room in a hypertensive state and was eventually pronounced dead. An almost similar thing happened to one of the best scientists of our time, Dr. Albert Einstein, and the cause of death for both cases is ruptured aortic aneurysm. And these are not isolated incidents. In 2013 in USA, we lost 19,000 lives to a ruptured aortic aneurysm, and throughout the world, we lost about 160,000 lives in 2013. Unfortunately, this is not very well published and people doesn't know, but this is a killer disease that we lose our relatives, our friends, and colleagues every day. During my presentation, I will show you some slides, radiology slides, but what I will not do and what I will not dare to do is try to read the radiology slides in front of all these radiologists, because as you know, when a surgeon tries to read a radiology study, the results are not very good. So coming back to our topic, aneurysm, the word aneurysm came from the Greek word aneurysma, which basically means defect. So whenever a normal artery is bigger than twice the size of normal diameter, that's defined as an aneurysm. And why would that happen? Cause is multifactorial, but the most cause that we deal with every day, and what I'll talk more, is atherosclerosis. And the minute I say atherosclerosis, some of my students always say, oh sir, you're wrong, because atherosclerosis causes the hardening of the artery, so why would it cause the weakening of the artery? So let's try to look at it. Now, I'm sure many of you remember your basic science lectures from medical school. So briefly, artery has three layers: the media, intima, and adventitia. The strongest layer, the muscular layer, where you get the nutrition from the vasa vasorum. So whenever there's atherosclerosis, the nutrition supply to the middle layer is compromised. And that creates a series of mechanical and biochemical changes, which I'm not going to bore you explaining. And in fact, I don't understand myself. One of my students, he made the slide I just reading over. So, but the summary is that whatever is the cause, you and I have a problem. The problem is that there is a big aneurysm, and you as a radiologist and me as a surgeon, we have to work together and make sure the right diagnosis and we treat in the right time. Because most of the aneurysms are asymptomatic, and it is diagnosed mostly by you, the radiologist, because the PCP will send the patient for acute cholecystitis and he will say, there are some gallstone, there are some fluid here and there, but the main culprit for this back pain is the 6 centimeter aortic aneurysm. And it's better we diagnose it when it's asymptomatic, because if we don't, a disaster is going to happen. And that's what happened to Albert Einstein, that's what happened to Lucille Ball, and that's what happens to 19,000 people per year in USA. And why would this disaster happen? I'm not a physicist, I'm just a dumb surgeon, so I don't understand physics. But the basic law of physics is that if your diameter is higher, the pressure that you require to disintegrate the wall is less. So bigger the diameter, the lesser the pressure you'll need to disrupt the wall. As I said, I'm not a physicist and I'm not a smart person, but what my mom told me when I was a little child, that look, if you're going to play with the balloon, don't inflate the balloon too much, because if you inflate the balloon too much, you know what's going to happen. So what is that too much? What you as a radiologist have to know, then when to pick up the phone and say, hey, Dr. Islam, you got a trouble, you better come and take care of it. And here's a list. If the diameter is 4 centimeters, the rupture rate is literally nothing. But as it grows up, you know when to pick up the phone. Because in the USA, my patients come and tell me, oh, my doctor told me I have a grenade in my abdomen, so please take care of it. As I said, most of the diagnoses are done by you people, the radiologists, but if a PCP is a smart doctor, if a good physical exam will, you can feel a pulsatile mass. We lost power here? If the PCP does a good physical exam, and I always tell my students and the fellow, forget about the CAT scan and everything, do a physical exam. And if you do that, you possibly can feel a nice pulsatile mass. And from there, you can order an ultrasound, which is a good screening study, MRA, CTA. I don't routinely do it, but when I decide that I'm going to do a repair of that, then I go for CTA, and we'll talk about it in a second. So let's talk a little bit about the treatment of the aortic aneurysm. I read somewhere that one of the Egyptian pharaohs, he died of ruptured aneurysm. And in ancient Greek study, there was quite few mention of the aortic aneurysm, but unfortunately, until late 1950s, there was no effective treatment for aortic aneurysm. The person who really pioneered the treatment, and I'm proud to say that I'm his direct student, Dr. Michael DeBakey. He's a son of immigrant like you and me. His father came from Lebanon, and when I was his fellow, he used to call me my first name, Mohammed, and every day his first question was, during the round, how many wives do you have, Mohammed? And I said, I still have the same one. He said, how come you don't have 4? I said, I wish I had 4, but I'm stuck with 1. So, well, Dr. DeBakey thought that, look, you have a dilated sac, and the fluid goes into that, the blood goes into that. So if somehow I can cut off the blood flow into the sac, I can create a new route, then there will be no rupture. So what he did, he opened the abdomen, he opened the retroperitoneum, he dissected the aneurysm and went to the above and below the aneurysm, opened the sac, and put an interposition graft. It sounds very easy, doesn't it? But in fact, it's not very easy. It's a pretty bloody operation. Sometimes you stay in the operating room for 4 or 5 hours, and if any of you walk inside the operating room, you would have seen something like this in early 90s or even early 2000. And when you repair the open method, you have quite a bit of complications. You have pseudoaneurysm, you have MI, you have infection, all kind of things. And unfortunately, some of the people, they never really get back to normal life. So in 1980s, from the SAARC nation of Argentina, Dr. Juan Brody, a very good friend of mine, he started thinking that, well, what can I do different than Dr. DeBakey and what the other guys are doing? Instead of opening the big belly, why can't I do from within the lumen? And what he did, I know some of you may not like it, he took a cow and injured the aorta and created a pseudoaneurysm. Then he would go to the femoral artery and put a stent graft, covered stent graft within the aortic lumen and stop the flow into the false sac. And I told him one day, Juan, you're lucky you didn't do that in India, they would have killed you. But anyway, so that was the main principle, that if you can isolate the aneurysm and stop the flow by giving a cover stent within the lumen without doing all this big surgery, and that will prevent your situation. And that's exactly he did. So if you look at it, That's the aneurysm. We go from the femoral artery on the ipsilateral side. We deploy the stent right above the aneurysmal sac, infrarenally, and depending on the involvement distally, nowadays we do bilateral femoral or iliac deployment. And so you have a new route, the blood is flowing into the new route, and there is no flow into the sac, and that gets thrombosed off. So if you look at two pictures on the top, that is the open aneurysm we are doing in until 2000. But now the patient on the bottom, that's what we do, everything percutaneous. So when I decide that I'm going to repair an aneurysm, this fits all that criteria, that is where I need you, my good friend radiologist. So we do a good dynamic CT and we do 3D reconstruction. And what I want Dr. Kamlu Naha to tell me, how far is the distance from the renal artery, how is the proximal neck, how is the distal, because that's what I'm going to anchor. That's what I'm going to anchor proximally, and I'm going to anchor distally. So if your iliac artery is also aneurysmal, I have to measure the size. And if your hypogastric artery is also aneurysmal, I always invite my interventional radiology friend to come and embolize the hypogastric. Sometimes in a university hospital, it creates problem because the vascular fellow, he wants to do it. The radiology fellow, they want to do it. I say, okay, you better fight between you and then say whoever wants to do it. But I always prefer my radiology friends to embolize the hypogastric artery. So, as you can see, we deploy the stent from the right side on the main body, and the contralateral extension limb we go from the left side. On the right side, we use the 18 French sheet, and on the left side, we use a 9 French.